To all of you, and welcome to our webinar, Use Hearts for Every Heart, Everywhere, which marks the celebration in anticipation of the World Hearts Day celebrated in September. Some instructions for the participants. We see that we're having more and more people joining us, and it's important that you send us your in the Q&A icon, which is at the bottom of the screen with the Q&A. And you can also greet us if you wish. You can write to us. You can tell us what your position is or any doubts in the chat. For anything to do with specific questions of the speakers, please do so in the Q&A icon. This webinar has interpretation into English, Spanish, and Portuguese. You may choose the language of your choice by going to the icon at the bottom of the screen that looks like a globe, and you can choose your language. You click on that and it gives you the choice of the different languages. You must turn off original audio and just choose the language you wish so that you won't be hearing both languages simultaneously. I'm now going to give the floor to Dr. Pedro Ordúñez, who is the advisor and leader of the Hearts Initiative in the Americas, so that he can say some welcoming remarks. Dr. Ordúñez. Thank you, Jenny, and hello, colleagues. And thanks for this opportunity to connect again in this webinar celebrating the World Heart Day. As you know, the World Heart Day is celebrated every year on the 29th of September, led by the World Heart Federation. And all countries in the world join one of the most important celebrations in terms of health. So today we have the pleasure, in advance of the World Heart Day, presenting this webinar using hearts, and we call it Hearts in Spanish as well, paraphrasing the World Hearts Federation slogan. But in this case, we're using hearts for all hearts everywhere. And that's the idea, that the Hearts Initiative in the Americas is the WHO and PAHO to care for cardiovascular health so that it expands throughout the region. Today, it is a pleasure for me to introduce first, to hear the opening remarks of this commemoration, Dr. Ansel Hennis, the director of the Non-Communicable Diseases and Mental Health Department of the Pan American Health Organization. Dr. Hennis, please.
Good day, everyone. And my name is Anselm Hennis, the Director of Non-Communicable Diseases and Mental Health at the Pan American Health Organization. And it indeed is my privilege and pleasure to welcome each of you to this webinar, Use Hearts for Every Heart, Everywhere. And this webinar is being presented in observance of World Heart Day, commemorated the 29th of September every year. The Pan American Journal of Public Health, as part of its 100th anniversary celebrations, has dedicated a special issue to the Hearts Initiative in the Americas, highlighting its implementation and impact on improving hypertension control and the prevention of cardiovascular disease in the Americas. Now, as you may all be well aware, the purpose of the Hearts in the Americas initiative is to improve the treatment and control of hypertension in all countries of the region. And to date, this initiative has been implemented and expanded in 24 countries, and where more than 2,000 primary healthcare centers now implement the Hearts protocols to the benefit of approximately 20 million adults in the respective catchment areas. By way of an update, the Hearts treatment protocols now fully implement the 2021 WHO guideline recommendations on the pharmacologic treatment of hypertension in adults. Furthermore, the Hearts methodology for protocol assessment and hypertension control drivers offer an excellent opportunity for fully implementing these new guidelines. Furthermore, there's been a tremendous growth in training and education through the HEARTS initiative. And this has been particularly targeting personal and primary health care. And to date, we've had a few tens of thousands of persons who've already completed the virtual campus courses offered by the HEARTS initiative. As a result, the articles which are being published in the Pan American Journal of Public Health on the HEARTS initiative are yet another way to support the comprehensive process of training healthcare providers and providing up-to-date information. So this special edition of the Pan American Journal of Public Health on HEARTS in the Americas initiative provides a comprehensive overview of the advances in hypertension care which have resulted due to the efforts of this initiative. Today's webinar provides key insights into the achievements in the work to date, and I'm sure that you will all take advantage of the information that will be presented and fully participate. Thank you so much and welcome.
Muchas gracias, Dr. Hennig. Como dije, director.
Thank you so much, Dr. Hennis. As I said, non-communicable disease and mental health director of the Pan American Health Organization. And as he rightly said, 24 countries are already, but let me confirm for a second, now that the room is getting more and more people, what are the new countries that have joined? We have added officially to date 24 countries. The most recent ones were Belize, Suriname, and St. Vincent and the Grenadines. So I would like to welcome them and congratulate them on behalf of the HEARTS organization, the three new countries, Belize, Suriname, and St. Vincent and the Grenadines. This has been very important in the Caribbean, since most of the Caribbean countries have already joined or are now joining the HEARTS initiative in the Americas. Dr. Hennis also mentioned that today the entree will be the presentation of a special publication dedicated to HEARTS of the Pan American Journal of Public Health. So it's such a pleasure for me now to introduce Dr. Damian Vasquez, the head editor of this Pan American Public Health Journal, to present this new special publication. Welcome, Damian, and I hope you're doing well, and I give you the floor. Thank you, Pedro, and good morning to all of you. I just wanted to know that you do see my screen I'm sharing. Can you see it? Yes, we do. Thank you very much for this opportunity to speak briefly. Basically, what I wanted to share with you is the message of the 6 words you see on the title, which is how the scientific information can be turned into actions in health. But before I get into the subject, I'd like to share again the fact that the Pan American Journal of Public Health is one which is reaching its 100th anniversary in 2022. And the journal has been the result of increasing and gradual development of all of the activities during these 100 years. We're showing you a photograph right now in which we see a picture that's spent 100 years turning that journal into one of the oldest public health journals in the world. In the journal, we could say that, very simply, our work is to transform what's on the left of the screen into what's on the right of the screen. The differences are evident. However, these differences which are evident are not the most important. Manuscript is a text which has not been reviewed, while a scientific paper has been peer-reviewed. And though the peer review is not an infallible method, it does act a lot of quality to the articles. A manuscript is not edited while a scientific paper is, which adds another layer of quality. But this is the most evident, however, not the most important. The most important thing is that a manuscript is a document shared amongst a group of authors and a journal. Only the authors and the journal actually know of the existence of this research or the data. A scientific paper, on the other hand, is scientific information, it's scientific evidence which is published and available for the different people, including the academic community, health professionals, the decision makers, and the public in general. And here's where the things become interesting, because each one of these groups can change their protocols or their treatment. And in this case, that could mean the use of measurement or pressure measurement devices to change the protocol in different ways with different pills that may be better absorbed or with better bioavailability. The decision makers can use the evidence to implement new regulations with better labeling on the foods, like, for example, the trans fats, or the purchase of more accessible and easier to implement drugs. And the general public can become aware of the new measures, the changes of lifestyle. Here in this information, which goes from the article to the public in general, there's the mass media, the education through schools, different mechanisms participate in getting the information to the public in general. So we have a type of virtuous circle, because something which was limited to a group of authors and a magazine, when it is in the environment, in the community, it begins to have its own life. So I'd like to invite you to visit the website of this journal. You have the website up there, and if you go up, you're going to find a session with the most recent publications, and you'll see the image on the screen and below all the titles of the articles. And it will take you to the complete text, which you can download with no restrictions and free of charge. In the web site, we have more than 15 articles, 25 original articles, plus 6 translations. As you see, they deal with different subjects and in different countries, from mortality due to ischemic heart disease or stroke, or health policies related to the implementation of HERTZ, the costs of this in the different countries, the satisfactory experiences in different countries, what's worked, what has not worked. It's a publication which deals with many different topics, and that's why it is so rich, because it does deal with different approaches of the same topic, which is hypertension control. And there are different experiences from different countries, which can be particularly interesting for some countries, or for those countries who share common factors in their health systems. And to end, I'd like to say that sometimes to publish is a team effort, is a shared effort. And I thought it would be interesting to count the number of people who have direct influence or direct impact on a manuscript. The manuscript would then be available in all the different databases where the magazine is indexed. Then there are 4 people from the editorial team and 1 administrative staff. That's 23 people, just very quickly, for a single manuscript. And in this special publication, we've had donors, partners, the editorial committee, and other institutions who've also supported this initiative. And all I have left is to say to all of these people, and to all of you who are here today in this webinar, who will be interested in the articles, thank you very much. Truly, thank you very much from my heart. Thank you so much, Damien. Excellent. I think that this makes the magazine have a closer contact with people, showing how it's produced and showing how the information which magazines produce can help transform the lives of people. Because in the end, our hope is that this will serve to change the lives of people. And it would be interesting if your team could tell us at the end of the webinar, at some point, how many authors have been involved in this, because I was surprised to see the number of articles and the number of people who work to publish an article. So then we could see the number of authors we have approximately. And maybe your team could help you in that, because I think that's been a tremendous effort. As we said, we're celebrating 120 years of PAHO, 120 years, 100 of the magazine, the journal. And one of the conditions that kills the most number of people anywhere in the world every day is this. And that's why it's so important for us to meet here today. That's why this webinar is a key element to help countries participate in the implementation of HARTS. I'd like to greet, taking advantage, Damian, that you write to us in the chat where you're from. I have recorded a massive participation of Costa Rica. I don't know how they're doing it, but Costa Rica is very present. I'd like to greet Mexico, Peru, Chile, Dominican Republic, Trinidad and Tobago, Guatemala, Colombia. Interestingly, Cali, Colombia, Panama. I have a surprise to tell you about Panama. I'm not going to tell you now, but we have places that are not in HARTS and yet they're participating. Puerto Rico, Cayman Islands, and Australia. Imagine participating in our webinar. But I'd like to invite you to read the publication of the Pan American Journal, and our production team is going to let you know how you can reach the website to use these or read these documents that are being published in this special journal. Thank you, Damian. Thank you for your presentation. That was excellent. Thank you, Pedro. This is going too fast for us to try to read what's on the text, but it is more or less a repeat of what Damien said. And I believe it's going to be shown in English in a few minutes.
Bueno, muchísimas gracias a la producción.
Thank you very much to the production team. Throughout the webinar, you'll see in the chat that there's the link you can use to access the magazine, but it's also a way to disseminate what we're doing. So now we're going to go into the first segment of our session, which will talk about populational control of hypertension and the role that cardiovascular mortality plays. So with no further ado, I'd like to introduce Ramon Martinez, specialist in heart and health metrics in non-communicable diseases, one of the authors or the key author of a paper, an article, which analyzes exactly what association there is between hypertension control in the population and cardiovascular disease. Ramon, you have the microphone. Thank you very much, Pedro. It is a real pleasure to participate in this webinar with you today, and it is a privilege to have contributed to the HARTS initiative in the Americas. Well, first, my name is Ramon Martinez, and I work in PAHO at the Non-Communicable Diseases and Mental Health Department, and my role basically in stroke mortality. So we know from clinical studies that if we control hypertension, we are able to reduce mortality due to cardiovascular diseases. And in this case, we've used two important sources to estimate the mortality as well as the estimates for prevention, prevalence of hypertension, and the hypertension treatment cascade to ecologically use the data from 36 countries of the Americas for 30 years, quantify ecologically this association. So I will be talking about summary of the mortality from ischemic heart disease and stroke. I will also show the level and trends of the treatment cascade for hypertension. We'll show as well the association there is between the population hypertension control and mortality due to IHD and stroke. And finally, I will show you a tool that has, to a certain degree, helped us implement the findings of this study in public health. So let's begin by showing you the ischemic heart disease and stroke mortality. Notice and this is for the region. We're giving you information for the regions of the America. And look at the enormous progress in mortality. There's been a significant decrease, a really important decrease in these 30 years. However, you can see that in the most recent years, maybe starting 2010, there's been a deacceleration, a significant deacceleration of this trend, this decreasing trend, both for ischemic heart disease as well as for stroke. And on the other hand, the region of the Americas has a tremendous variability in the mortality level due to these causes. You can see that there are countries where, for example, like Guyana and Haiti, the mortality rates are extremely high compared to other countries where the mortality rates are much lower. And we could say that the countries in the worst situation have twice the amount of mortality of those situations that are in the best situation, that have the lowest rates, like Canada, Puerto Rico, or Peru, which shows us that there has to be a contextualized treatment for each country. In other words, each country operates differently. That's clearly reflected in these differential levels of mortality. On the other hand, we have a serious problem with the treatment cascade, particularly with one of the most important measures, which is the population control of hypertension. And I'm showing you a chart here showing the last 30 years in the region of the Americas for both sexes, the progress attained in populational control. And you notice that despite the enormous progress in population control of hypertension, there's still a very high number, a very high rate of hypertensive persons who do not have their hypertension controlled. In fact, there's an important number of hypertensives who don't even know that they are hypertensive. So this is a fundamental element when dealing with or treating or trying to reduce hypertension or implement the measures to reduce hypertension due to cardiovascular diseases in general. So if you notice also, there is an enormous variation or variability in the population control of hypertension in the countries where, for example, we have countries that have very good control, like in the case of Canada, where 60% of all hypertensives are controlled. And yet we have other countries like Haiti or Paraguay, where the hypertension control in the population is very low. So there's an enormous variability. And this is a wonderful opportunity for us to be able to work with the countries of the region of the Americas to increase or scale up or improve the hypertension control in the population. We see that in most of the countries that have the hypertension control low, most are countries that have social and demographic indexes that are very low. And there are countries like Argentina, for example, where despite being a country that has very high development of social and demographic development, the levels of hypertension control in the population are really quite low, of about 11%.
So this means that we need to work in a customized manner with each country in order to be effective in our hypertension prevention and control programs. This is a key finding. I was saying that we studied data from 33 countries over 30 years, and we found
de incremento del control
that
poblacional de la hipertensión es posible lograr
for 1%, for each 1% increase in hypertension in the population, we can achieve 2.9 reduction in IHD and a 2.4% reduction in stroke mortality. This is major information because it enables us to work with the countries
que nos permitan estimar cuánto
and
podríamos
seek actions aimed at identifying how many deaths could be prevented if we can increase hypertension control in the population. As a result of this study, we were able to not only identify these figures, but we also developed statistical models that enable us to estimate these data for pretty much any kind of population in any given country, etc. So now I'm going to show you
existe, por supuesto, un grupo de intervenciones.
there is a series of interventions which during this webinar in the next segment we're going to hear more about. And those interventions that you see on the left have an impact in that we will be able to increase both detection and diagnosis, as well as improving hypertension treatment and follow-up of hypertension patients, and finally being much more predictive in terms of people that have IHD. So these three sets of actions can truly have an impact on population hypertension control through this equation. So our study provided some regression models that enable us to, in this case, predict how many deaths could be averted if we increase or improve hypertension control in the population. So in order to take this to the public health field, we have developed a tool that is based on the statistical models that we developed in this study. And I am now going to briefly introduce you to this tool. The tool is available on PAHO's website, and earlier I shared the link in my previous slide. So let me show you. Give me a second. So the tool is divided into two sections. You see a column on the left where we have the different parameters that we can customize based on different scenarios. For example, you can include the population name, the country, etc., that we'll be studying, define the population, to define what kind of interventions we want to have to improve hypertension control. So we have these three parameters: diagnosis, treatment, and then hypertension control in people receiving treatment. In this case, we're showing the information for the region of the Americas, where currently the prevalence is 36.4% for hypertension control. I'm going very quickly.
Ramón,
Ramón,
herramienta no se está viendo. Estamos en la misma lámina
we are
todavía.
still seeing the static slide. We are not seeing anything you're doing with the actual tool. Oh, let me check. Yeah, because this is important, and you can see, well, Ramon takes care of that. You have the link where you can find this special issue, and including the link to the tool. Oh, now we can see the live tool. Oh, my apologies.
Si logro, vamos a refrescar aquí un momentito. Ok, entonces, esta es la herramienta. Déjenme.
So, this is the tool.
O sea, confírmenme, voy a tratar de ponerle toda la pantalla. Confírmenme
Can
si.
you please check whether you can see it in the whole screen? Yes. So, as I was saying, the tool has two main components. On the left, you see that we have the different parameters that enable us to develop a scenario to estimate, in this case, the number of deaths that could be prevented if we make changes to hypertension control. And then to the right, there is a more visual section that plots the results for the scenario we are building. So here we have the location, region of the Americas, where we have roughly 1 billion people, and in 2019, population hypertension control was 36.4%, and our target is 50.4%. So you can see that both for IHD as well as stroke, this graph shows us the mortality levels that are expected for this population hypertension control that we entered here on the left. So the total number of deaths is this one. These are the deaths that could be averted, and these are deaths as a result of IHC or stroke. Here, we could say, okay, let's see if I want to take this baseline level for diagnosis from 69.8% to, let's say, 90%, you can see how hypertension population control changes. And in this case, we get new figures for averted deaths as a result of these two diseases. Finally, here on the bottom, the tool has a section that enables us to set a time frame for our prevention and control program to achieve this increase in population control. Let's say let's set 7 years as a timeline. So down here, we can see how many deaths could be averted in each year until we get to the final figure. And finally, here on the bottom of the screen, we see a key message that we can use to share with our national authorities, decision makers, program developers, etc. I'm not going to go into a lot more detail on this tool because later on we're going to share with you some case studies using this tool. So this concludes my presentation for now, and thank you for your attention. Perfect. Thank you so much, Ramon, for your presentation. which is a segue to two panelists. The first one I'm going to introduce is Dr. Alvaro Sosa Leipandi, head of the Inter-American Cardiology Society, which is one of our partners. This Inter-American Cardiology Society is present here in the region, and it has collaborated closely with PAHO. And Alvaro Sosa, with a group of collaborators, has written an article on something like hypertension is still unfinished business. And that's not my word, but rather the words of the Cardiology Society. So I would like now to have this summary of this article by Alvaro Sosa, and then we'll go back to that. So go ahead.
El control de la hipertensión arterial.
Hypertension control and an unfinished business. The proper diagnosis, treatment, and control of hypertension continues to be an unfinished business or a pending topic in our attempts at reducing premature death and disabilities. This is a global reality that is particularly true in the region of the Americas. Even though we have correct algorithms, diagnosis, and treatment options, the gap between medical knowledge and reality shows a great difficulty in having our recommendations adopted by our countries. Accession is a huge challenge, and the proper understanding of all of its dimensions is basic when we develop strategies to improve hypertension control. It is clear that having and disseminating correct information is part of the equation, but just as important is to have actions that ensure implementation. And that is why I would like to welcome the guideline for clinical practices that address this issue. The recent publication of this guideline by the WHO for the pharmacological treatment of hypertension in adults is an example of these types of actions. Implementation programs may be one of the biggest challenges in our modern medicine. The development of multimodal interventions at the first level of care in order to improve their resolution capabilities and promote the networking of health services appears to be the most appropriate pathway to reach appropriate hypertension control levels. We are convinced of the important role that these scientific associations have in this by providing support and articulating the interaction and engagement with the different stakeholders.
Bueno, muy bien. Yo reitero, el presidente de la
Okay, I reiterate, the president of the Inter-American Cardiology Society is saying this, and he's saying that the hypertension control issue is an unfinished business for the region. So I would like to ask Mr. Alvaro Sosa, why is hypertension control an unfinished business? And what recommendations do you have for the colleagues that are listening to this webinar? We have a lot of cardiologists here. And you looked at these figures that Ramon Martinez introduced. That is to say, the deaths that could be averted if we go from 30 to 50% population hypertension control. We can avert about 500,000 deaths just in our region. So let's hear from Dr. Alvaro Sosa. Go ahead, please.
Muy buenos días a todos.
Good morning, everyone. First of all, I would like to thank you for this kind invitation to share some information with you and reflect on this very important topic. First of all, after this brilliant presentation by Mr. Martinez, it is very clear that it is extremely important to have hypertension control in the cardiovascular disease burden in general terms and specifically in our region. Obviously, the huge impact between hypertension control and ischemic heart disease or stroke is extremely important and undeniable. And even though we have heard that some improvements have been made over the past 20 to 30 years in a region, obviously, even to this day, we're very far from achieving optimal figures. And if our region, we're talking about 35% population hypertension control, 25% men, 40% women, we can say that we are very far away from achieving our optimal figures. And we can say that hypertension control currently for us and for our region is undoubtedly an unfinished business. Obviously, over several years, our scientific associations have been highly committed in developing information to try to deliver correct information on diagnosis, treatment, and therefore having as a goal hypertension control. And we are witnesses to a huge effort by the international scientific community to develop clinical practice guidelines to take this information mainly to our medical community, both in our region, in the Americas, as well as in Europe. Even though we have some differences and different approaches that had to do with the diagnosis methodology and some slight contradictions in terms of treatment threshold, they are a true effort, like I said, by the international community to deliver information and try to standardize diagnosis and treatment. But in view of the results, we can say that even though the information is a first step or the primary link to a solution, obviously it is not enough. And obviously, we need to take into account other elements other than knowledge. The huge gap that we have between knowledge and action, that is to say, between the information we have available and what actually happens in the real world, is a huge challenge to all of us. And this holds true for hypertension as well as many other medical conditions. This huge gap, like I said, between information and action is a true challenge. To try to understand what the true barriers are, the barriers to each one of our actors. And when we talk about barriers, we need to talk about barriers that doctors face, that patients have, and that and between the doctors and patients and these two and our medical systems. If we think about physicians only, with information available, we cannot say that information is easy to access, but there may be differences in interpretation. There may be some guidelines that may not be implemented universally everywhere, but most importantly, there are issues that have to do with the way in which we face uncertainty. As you well know, the physician's prescription model is shaped in the initial 10 years of someone's career, and to change that and to change the way in which we face uncertainty is oftentimes difficult. Today, we know that we need at least 2 drugs to control hypertension, and fixed doses are a much better option than giving a single drug. However, that means in the way doctors prescribe, and sometimes us doctors are resistant to this change. This medical inertia is a very important issue to take into account. And then among patients, there are a lot of barriers. I would say over 100 barriers between doctors and patients, but we can say that polypharmacy, a lot of multi-pill, socioeconomic conditions, lack of access, educational level, etc., are elements that somehow negatively impact a patient's adherence to our recommendations or insist on or maintain the recommendations that we make. That is to say, for the patient to remain consistent over time. And adoption of recommendations is a huge issue. We know a lot of patients over the first 6 months stop taking medication or do away with our recommendations. And finally, as we said before, between us and patients, that is between physicians and doctors, we have our healthcare system, different healthcare systems. We know that our region is heterogeneous with a lot of inequalities, different healthcare systems, different levels of fragmentation, and therefore different levels of access, not only to treatment, but also to just health care systems in general. This is extremely important, and acknowledging each one of these barriers is key when we start thinking about a solution, which takes us to a topic that's extremely important, and that is implementation. That is to say, going back to the beginning, how can we make our recommendations reach our patients? How can we develop implementation programs that in a way ensure that this happens? And more likely than not, this will be one of the biggest challenges that our modern medicine currently faces. This holds true for hypertension as well as many other medical conditions. And therefore, this is also a huge challenge for all of us. Well, thank you so very much to Dr. Alvaro Sosa, like I said, president of the Inter-American Cardiology Society and one of the big champions for hearts in the region. I wanted to continue with this webinar by, excuse me, there's interference from another microphone. I'd like to go back to an issue that I think is key. We have a surprise to do. Towards the end of our webinar, we will have the president-elect of the World Health Foundation, Dr. Daniel Pinheiro. And you can see that in our upcoming cardiology Congress that will take place in Rio, in Brazil, in October, one of the roundtables would be around hearts. This is to show how important this initiative and this topic is in order to make collective progress. And since we have Alvaro here, and knowing that he's Argentinian, we will also be at the Cardiology Congress in Argentina, which is one of the biggest cardiology congresses around the world, addressing the issue of hypertension and see how we can implement hearts in Argentina. By the way, before moving on to our next panelist, I'd like to mention the new countries that have joined us. Mexico, from all over Mexico. We have all kinds of Mexicans that are part of this webinar: Culiacán, Guanajuato, Campeche, Zacatecas, Tabasco, Veracruz. And I also want to send greetings to our colleagues from UNAL, Mexico. Cuba, Suriname, Belize, Guyana, Argentina, and Bolivia are in hearts. Then I'm going to read the countries that are joining us but are not part of hearts. So now, moving on to our next panelist, we're going to hear from Dr. Beatriz Chantan, who is a tireless civil society leader and one of the authors of a publication that we will be introducing. Beatriz, I am sure that we're going to have to emulate what the civil society has done for HIV/AIDS, but we're going to go back to that after your section. So just as an introduction, I would like our technical support people to show Dr. Beatriz Champan's article and her collaborators at the Pan American Journal on Public Health.
Despite efforts in Latin America to implement the HEARTS initiative, hypertension control is still inadequate. There are many advances in the medical and technical arena, but little to promote political and systemic change. The vibrant civil society that has advanced policy change in tobacco control, food policy, and other public health initiatives can make a crucial contribution to prioritize hypertension control in the political agenda, ensure sustainable funding, promote the procurement of affordable and effective medications, and expand community demand for action. The recommended first step for civil society's involvement is to analyze the political landscape to design an advocacy plan. The political landscape includes a legal analysis, policy mapping, stakeholders mapping, identifying obstacles, mapping community strategies, and risk assessment. The second step is to define policy goals and an advocacy strategy. Based on experience, there will be two main policy goals: to increase political will to make hypertension a top priority, securing necessary resources, and strengthen community awareness and social demand for action. The third step is to develop and implement the advocacy plan with the tools familiar to civil society, including building a case for support, advocacy towards decision makers, media advocacy, coalition building, countering the opposition, and civil society monitoring and accountability. To jumpstart this approach, there should be incentive for civil society and a transition for transferring competences to a new arena. The results could be more sustainable and scalable hypertension control, better health outcomes, and advances toward the 2030 Sustainable Development Goals and universal health coverage.
Bueno, excelente resumen de
That's an excellent summary of this issue by Dr. Beatriz Champagne. So, Beatriz, once again, welcome to collaborate with us. You were part of the World Hypertension Day, and now you are part of the World Heart Day. I know also that, and this was also a pleasant surprise that will be shared by the person that coordinates the Roundtable on Hearts at the World Cardiology Congress. My question is, why do you think it is important that civil society plays a role in controlling hypertension? Because this is an important topic for you. And the figures that Ramon mentioned a while ago in terms of how many deaths could be averted is important. What would you like to say? First and foremost, Pedro, I would like to thank you and the entire Hearts and PAHO communities, and congratulations on the 100 years of PAHO and 75 years for the journal. It is a true pleasure to have been given the opportunity to write this article, which I believe is a proposal, because several people have been discussing the need to influence health policies. However, this proposal further defines what this civil society could do. First of all, we must say that there is a lot of information. There are a lot of studies. We have protocols, success stories, essential medicines, clinical guidelines, etc. So there is a lot that has been done from Hearts. Now, this proposal aims at supplementing what Hearts has done. And I would like to clarify that here, we're talking about an issue that we're familiar with, that we have a lot of information about. However, it's been hard to implement, like Dr. Alvaro Sosa said a few minutes ago. Civil society, as a community that I'm a part of, that I'm here representing today, has been working on topics that impact hypertension for quite some time. So we have worked a lot at the population level with population interventions. For example, front of package level labeling or warnings on food to reduce sodium intake in our diets, elimination of trans fat. This Monday, by the way, there's going to be an event in Mexico that we hope and we hope that the legislation around trans fat goes to the House of Representatives, and ultimately Mexico approves elimination of trans fats. Physical activity, and let's not even say anything about tobacco, because we've been working on that for over 20 years. But we are slightly invisible because we work behind the scenes. And when the time comes to celebrate our success, we have the authorities, politicians, and civil society who had an opportunity to organize all the action to move the political agenda forward is not present and is not on the official picture. So I'm talking about going above and beyond population level interventions. We're talking about what civil society can do in individual interventions and how we can provide support in that aspect. On the video, you heard the main interventions that we are suggesting, but we need to take into account that hypertension and health are a government's responsibility. Civil society cannot and should not have a parallel obligation to address the needs of our countries. Rather, their responsibility lies in our governments.
Civil society has to support in order to create the demand from the level of the community and the persons who are living with these diseases, who sometimes aren't organized sufficiently, do not have a strong voice. Those people are the ones that can help us create the demand. And in creating the demand to set up this question of hypertension and its control would be installed within the policies or politics, because we're not talking about something that is simply medical or scientific here. What we're talking about is a political gap. And what we do with this proposal is that it shows us that we have to work with the politics. Very well. Thank you, Beatriz. Excellent, excellent thought. I think that there are another question that we're getting into. In the field of hypertension, there's a tremendous advance in pharmacology or pharmacopoeia. We know that there are medicines that work better than others. We know it's not the same for you to tell the patient that he has to take a medicine 3 times a day and that he only takes it once. It's not the same as you tell the patient, look, you have to take 2 tablets and he only takes 1 with the same component. It's not the same when you tell the patient that we have certain conditions to see you as frequently as you need. In other words, as you well know, we are going to start a series of webinars with this one during October, November, and December, presenting this special number of the magazine, of the journal. And we're going to talk about the clinical protocol of hearts, because we're talking about the clinical path of hearts has to be for the health providers as well as for the patients, because it is a way for the patients to identify good practices and what responsibility they have in complying with these. So the dimension of what civil society can do increases. And we have a golden opportunity to continue to advance. Thank you very much for your participation as usual. And I'm going to end with a paper from the Latin American Healthy Coalition, which is behind all this, so that you see how vibrant this community is and how all the countries in what we're doing with hypertension can join actively to make the difference. So thank you very much, Beatriz, for your participation. Congratulations for that article. I'm sure it's going to serve as teachings for many. And welcome again, Beatriz. And now we're going to have the presentation of the Healthy Coalition. population carries out a job in politics, education, NGOs in health, consumers, religious entities, academicians. Founded in March 2011, geared to reduce inequities, promote human rights, favor effective policies with impact on risk factors and the health determinants, I believe is what it said. I'm sorry. It's too fast. Thank you very much for that video. It gives us an idea of what's going on. And I want to invite you again. As I said, we started this series of Hearts webinars in the Americas with the Public Health Journal of the Americas. We'll have one in October, one in November, and another in December. It's the space for you, if you have materials like these, that class has shown us, we're open and willing to share all your efforts with the community. And I want to take advantage to congratulate and greet the new countries, or countries that are not in Hearts yet, I should say, who are participating in this event. I'd like to greet, for example, our brothers from Venezuela, Nicaragua, Paraguay, Uruguay, and Puerto Rico. Puerto Rico, despite the fact that it is one of the under the effects of a hurricane, we have Puerto Ricans participating here. So we really have to congratulate the Puerto Ricans and tell them that our hearts are with you. They have been affected seriously by this hurricane. And I'd also like to add that there are other countries that are joining. I don't know how they do it, but they've joined us and are greeting us. Several colleagues from different parts of the world, like Madrid, Spain, and Qatar, Malaysia, Switzerland, obviously United States. And the people who are rightly saying that civil society, scientific society's role is important, but aside from the theories and the academia and what we have to do, let's act, let's do things. And Beatriz Champagne had said quite rightly, let's empower the community, let's empower the patients so that we fight against hypertension and turn it into a cause. In the second segment, we're going to give the floor to one of the people who has participated in one of the most important programs of hypertension in the world. His name is Mark Jaffe. I want him to turn on his screen. Professor Mark Jaffe, head of the endocrinology service from the Kaiser Permanente Center in San Francisco in the United States. Mark Jaffe has been our consultant, our star, one of our star consultants from the very beginning of Hearts in the Americas. Mark, do you remember when we began with Barbados? And then we went to Cuba and Colombia and Chile, and you were with us at all times, and now we have 24. And I'm not even going to mention the 25th because I have it right here, and I hope that we're going to get it soon. But the idea is that we will have a community of practice where people understand what has to be done. And now Mark Jaffe has just published an article on the essential components of populational hypertension control. Professor Mark Jaffe, you have the floor. It's an honor to have you here today with us. Thank you. You have the floor.
Thank you very much, Professor Ordonez. And it was really great to be back with everyone and to see so many familiar names flash across the chat. So it's a great pleasure to be here. I'm going to set my timer because I was asked to talk about developing hypertension population control programs in 7 minutes. So I'm going to be mindful of the timeline, but just that everybody knows, it's going to take a lot longer than 7 minutes to disseminate this and to help improve hypertension control throughout Latin and Central America and the world. So let's go to the first slide. All of this information, it was recently published in the journal, which has been referenced. We had a wonderful presentation by some of the journal contributors in this, and as well as the journal editor. And so it's really a great pleasure to be part of this today. So everything I say here is going to be available with references, and there's a nice table in the article as well, which is going to outline what I'm going to talk about today. Next slide, please. So really, we're going to talk about the components, and the components really are can be boiled down to several different elements: leadership, screening, outreach and follow-up, treatment protocols, medications, task sharing, and monitoring reporting. Next slide, please. When we talk about leadership, this is really important because without effective leadership, it's really hard to get organized. The reason why leaders are important is because leaders can help organize. They can help prioritize. And when we have the ear of our leaders, they can help make things happen. But in addition, it's not only leadership at the national or state or international level. Really need leadership at all levels, at the clinic, at the county, at the hospital, at whatever site you're at. And so having what we call cascading leadership is really important. And that means that leadership is really not only it's not top down, it's not bottom up, but it's really all throughout. Next slide, please. In addition to leadership, screening, outreach, and patient follow-up is super important as well. Of course, we all know that patients come to see us, and we should take advantage of those opportunities and to screen for hypertension when people appear. But that alone is not enough, because in many settings, people don't come to the traditional care setting frequently, especially those with an undiagnosed and unknown disease, as was mentioned earlier. So not only do we need to do what we call in-reach, which is checking people's blood pressure when they show up, but also outreach. And the outreach has to be systematic. I've seen it done with lists, with communities, because if it's not systematic, you're likely to miss people. So although, setting up a booth on the corner, is good, it, might capture some people, it's really different from an organized, systematic process. And the process should really address the entire population at risk. And once people are screened, of course, it's really important to have a mechanism so that people can come back, so that once people are identified, there's some connection with some form of health care facility or process where the blood pressure can be confirmed, and treatment can be initiated if necessary, and patients can be followed. Next slide. So once you've got leaders, you've got screening, and you've got effective outreach, and you've got patients coming back, it's really important to know what to do. And a treatment protocol is really important. And treatment protocols really should be designed for not only the diagnosis, but also the downstream treatment. They should be simple, and they should be standardized. And one wonderful thing that many of us have learned through our implementation exercises over the past 10 years is that the whole process of developing a standardized treatment protocol can really be a wonderful way for consensus building. So we've seen many countries or states or even hospitals or clinics all participate together in coming up with their own simple standardized treatment protocol. And once you have a treatment protocol that's simple and standardized, it's easier to get medications and task share. Next slide, please. Medications are important, but of course it's usually easier to do that if you've already agreed on a standard treatment protocol. They should be the fewest number of medications possible with the fewest doses possible, and they should be affordable and low cost, and sometimes even no cost if possible. And of course, single pill combination medications really can help address pill burden. And we know that when people use single pill combination medications for blood pressure control, there are fewer, not more side effects, and costs go down and control goes up. Next slide, please. Task sharing is important, and think about it. And now if we have simple protocols, we have a simple set of medications, think about how much easier it will now be to task share, allowing everybody on the team to participate. We can have people working at their maximum scope, and it's more effective and allows for greater opportunities for care. Next slide, please. Monitoring and reporting, we heard a wonderful presentation earlier today about the power of data, but metrics are important, and metrics should be easy, they should be shared widely, and they should be distributed regularly. These allow people to compare themselves to one another. They allow our leaders to assess sites, to identify those sites who are doing really great, who ought to be investigated so that we can share their best practices, and also sites that and places that might need a little more help, who can learn from the successful programs. Next slide, please. So in summary, the components of leadership, screening, outreach, and follow-up, treatment protocols, medications, task sharing, and monitoring are really important. And all of those can really be the critical components of making a successful program. Pedro, I apologize for being 23 seconds over, but please forgive me, and I'm really just delighted to be part of the panel. Thank you.
Pues muchas gracias, Mark, por la genialidad de hacerlo breve.
Thank you so much, Mark, for making it brief, attractive, and intelligently. Mark is going to show us something else at the end of the blog, so you're not going to get away from us that quickly, Mark. And he's going to warn you on how to do a standardized protocol. But I want to say, Mark, that the room is full. I don't think we fit anyone else in Zoom. We have 500 participants. It's gone beyond our limit. No one's left. The room is chock-a-block full. Nobody fits, and they're hearing it. We have a certificate of participation for the first 500 who arrived. And we'll give you the instructions later on how to download the participation certificate. And I want to mention, you haven't mentioned Guyana. Guyana is one of the countries that has joined HEART, and they're doing it very well. And British Virgin Islands has also joined this webinar. I want to greet our friends from the Caribbean for their tremendous effort. But Mark, you're going to be happy about what's going to happen now, because you were talking about how important it is to have simple and standardized protocols for this control. And our colleagues from Chile, and listen to this, our colleagues from Chile, whom you know very well, they broke their record of participation in this particular number of hearts. And they're going to present to us now an article which compares the centers that have the standardized protocols to those that don't have the standardized protocols. And that's the title, which will be presented by Dr. Luis Michea, Associate Professor from the School of Medicine of the Chilean University. So I'm going to give the floor to them, and I want to thank Dr. Mark Jaffe for his participation, and then I'll come back with Dr. Luis Michea. The existence of a standardized strategy and simplified strategy for the treatment of hypertension in Chile, the HEARTS initiative in the Americas. Objective: evaluate the effectiveness of a standardized and simple protocol based on technical pillars of the HEARTS initiative in the Americas to control hypertensives in the cardiovascular health program at the first level of care in Chile. Methods. An observational longitudinal study was carried out in 2 primary healthcare centers in Santiago, Chile. Family health centers in Cespan, Florida, Cespan Jose Alto, since January 2016 to January 2019, comparing the blood pressure control in hypertensives, adults, with the standardized protocol vis-a-vis the usual protocol according to the national guidelines. The standardized protocol innovations included changes in the coordination of the health team, the beginning of drug treatment immediately after diagnostic confirmation, standardized drug treatment, combination of at least 2 or 3 drugs against hypertension in a single pill, in intake a day, following up for a year to evaluate the compliance with treatment and the control goals of the hypertension under 140 over 90 millimeters of mercury. 1,490 patients were evaluated, 562 used the standardized protocol, and 928 treated with the usual protocol. The Kaplan-Meier curve shows the number of patients who achieved the control goal. After a year of follow-up, the patient's control in the standardized and simple control group was 65%, a significantly greater value vis-a-vis that achieved in the other groups of patients following the usual treatment, where it was 41 in CISPAN Florida and 42% in CISPAN Alto 1 year after follow-up. This chart shows that the patients who received the standardized and simple protocol continued to receive their medication, showing a greater percentage of compliance with the hypertensive treatment compared to those in the usual treatment. The results of the study conclude that the standardized simple protocol with combined medications is more effective than the usual protocol for hypertension control in patients treated at the first level of care in Chile. Its implementation at a national level can contribute or will contribute to reduce greater cardiovascular events or major cardiovascular events, I'm sorry.
Bueno, excelente.
Well,
Yo creo
excellent. I
que
think
nos
that
deja la mesa sentada. Yo quiero
that shows clearly what can be done. I'd like to invite the colleagues from Chile to turn on their cameras. We have 3 speakers from Chile, right? 3? Why? Because that's the country that published the largest number of articles in this special issue of the Pan American Public Health Journal. I'd like to introduce Professor Luis Michea, professor from the School of Medicine in the University of Chile, Dr. Marcela Rivera. Marcela, your camera, reference of the National Cardiovascular Program of the Ministry in Chile, and Dr. Paula Silva, professional from the Non-Communicable Disease Department of the Ministry of Health in Chile. The 3 panelists have their cameras open, and so I'll start with my questions. You broke the record of participation. There's another paper that is also being considered right now, but has not yet been published. Dr. Michea, you have compared, I'm going to give the numbers, the group that did the standardized protocol was 65% of control after a year, compared to the 2 reference centers, 41 and 32%. So that was a clearly large difference between one and the other. So I know that Chile has used a resolution of the health ministry in that country. The implementation of the standardized simple protocol treatment is part of the National Cardiovascular Program. So my question is it worth expanding this? Is it worth emphasizing this matter, which seems so simple? And what would you say to your professional colleagues from other countries who are doing the same? Luis Michea. Well, thank you very much to all of you for this invitation and for this opportunity to show you our results. Yes, of course, it's really worthwhile. I believe that I don't have enough words to express my enthusiasm and my hope that this is an effective strategy, as we see from the results we've obtained. And as Professor Ordóñez said quite rightly, those of us who studied this work that is focused mainly on the treatment protocols and medications and the change in the work of the health team was tremendously beneficious in compliance and in the improved control. They're very, very hopeful. And we also were able to show that in these health centers, these primary healthcare centers, it was feasible, viable, and sustainable throughout the study period and even after that. where we've expanded it to others in the country. Yes, I definitely believe that it is an excellent strategy. And I think that the results are showing us clearly that it is going to benefit the population. We have some tools showing the impact, which could also be useful to estimate the cost effectiveness of this. Thank you. Very well. Thank you, Professor Michea. So in the webinar that we're going to have, the upcoming webinars, I don't know if it's the October or November, Dr. Jenny Rodriguez, who's our coordinator and the coordinator of this production and of this education and training entity, we're only going to show one webinar that's going to be dedicated exclusively to the clinical effectiveness, which is not only proven, but it also reduces costs. And the Mexicans got ahead of you there in the publication, showing that it also reduces costs and improves compliance, as you said quite rightly, and improves the results, of course. Of course, you say that you were able to achieve a 65% control. We still have to reach the level of Kaiser Permanente, which is about 80%, as Mark said, and in some cases up to 90% of his patients. So it's possible, right? So I'm going to ask Dr. Marcela Rivera, who's from the National Cardiovascular Health Program in Chile, and one of the authors of hypertension control rates in the public health sector in Chile, before and during the application of the Hearts Initiative article. How do you relate that work that you did, Marcela, with the need to have programs like these in the population? Based on what Mark Jaffe said and based on the results you've obtained. Marcela, welcome. Thank you for this invitation. And from the Ministry of Health, we are fully committed to the Hearts Initiative because the numbers are quite clear. There's no way to say anything different. The evidence is quite clear. We've seen it in the webinar and we've seen it in all the different studies that we've had access to. So at the Health Ministry, we're working with a great deal of enthusiasm to go to 100% of the health centers in the country. We've advanced despite the pandemic. I mean, the pandemic hurt us seriously as far as the number of people who lost their control and also lost their access. Today, we're working to recover these people so that they have greater access to their controls and their treatment. In Chile, we have a comparative advantage. Someone asks how we do it in the chat. Well, by law, we guarantee the treatment to the persons with hypertension. It's a state policy called HES. And that makes it easier for us to give them access to treatment. But despite the fact that the access is guaranteed, not all country is standardized. And that's our challenge. We have to standardize it throughout the country. We're working with all the people in the country. Many are here in this webinar, in fact, to show that we can expand this program because nothing better than the Hearts Initiative in the Americas. So you have a real partner in this. We're going to work to achieve 100% as soon as possible. Thank you, Marcela. I think that we have a great partner, yes, but we also have a clear example that can inspire the rest of the countries. I had a meeting a couple of days ago, and I'm not going to say what country it was with because I'm not allowed to, but when they asked me of an example, I said, look what they're doing in Chile. Look what they're doing. I mean, they went out into the field, they researched, they implemented the protocol, they have a resolution which is reaching all health centers, they guarantee access to the medications. And if that were not enough, Paula Silva is going to show us another result. Paula is one of the authors of another important paper which is being published in this issue, which is about the procurement profile of the blood pressure measurement devices. And I'm sure you heard me say in other webinars that a program as important as this one, if we don't know what type of device we're going to use to measure the hypertension and what safety do we have, what accuracy do we have. But I think you're doing that in Chile. And you published an article in this issue of the Pan American Public Health Journal showing what you're doing in Chile. So my question to you is, are you changing the procurement matrix? I think that's what you're saying in your article. You've changed the procurement matrix. How is that change being accepted, and what's the future of this? What do you think? Paula. Good afternoon.
Good afternoon, and thank you, Pedro. Actually, we're pretty happy with the outcomes of the study, and we have shifted public procurement to validated measurement devices. A few minutes ago, you mentioned this. We had recommendations from ICU to use validated devices. So we had a list of updated and approved devices for use in our national territory. Ever since this initiative passed, we have been able to see digital devices increase up to 75% of the total measurement devices. And the ratio of devices that were validated went from 34% in 2018 to 64% in 2020. Wow, I am speechless. So yes, we can. You are doing this in an orderly way so the system doesn't collapse, so the procurement doesn't collapse. So I would invite you to visit Hearts in the Americas website and check the list of validated devices and let your colleagues know and let the patients know, because sometimes patients go to a pharmacy, they just buy whatever devices. So it's better to recommend a validated device. One of the things that you commented on, Marcela, is that during the pandemic, as the case was in many other areas, there was a big impact on healthcare all over. A lot of things were overlooked, were postponed, were neglected, etc. You saw Mr. Martinez presented at the beginning the impact of increasing hypertension control. Let's keep our Chilean colleagues around to take a look at this, because we're using Chile as an example now, but let's look at this. If we change, and rather than improving hypertension control levels, the program deteriorates, or we see lower levels, what would the impact be in Chile? Ramon Martinez is going to show us how to project this. Go ahead, Ramon. Yes, thank you so much for giving me the opportunity to use Chile as an example. This does not mean, Ramon, that this will happen in Chile, but rather, hypothetically, if Chile overlooks its program, this could happen, right? Go ahead. Okay, so to begin with Chile's example, I have a tool. When you click on this, it's a menu that shows the treatment cascade data. These are like basic data that you need to use this tool. I'm going to select Chile. Chile is one of the countries in the region that has a population of over 19 million, with a population hypertension control of 33.7%, which is considered acceptable, of course. Awareness, 71.2%. Treatment awareness among those who are aware of the condition, 82.2%, which is very high. And here, 57.6% of hypertension control among population treated. So if I highlight Chile, the tool populated all of the data for Chile that are taken from this menu. So now I'm going to close this pop-up menu, which is kind of like a reference document only. And let's imagine that as a result of COVID and issues in access to treatment in general, there was a reduction in Chile. So rather than improving it, the quality decreased. So for diagnosis target, I'm going to have a similar figure, 71.2%. In terms of treatment among those aware, it's 82.2%. That's the estimate for 2019. And for hypertension control among those treated, 57.6. So hypertension control is 57.6. You can see that both our baseline as well as target values are similar. Therefore, the tool is telling me that, okay, well, given those conditions, there are no changes. Therefore, you're not averting any deaths. It is just showing that for the population hypertension control level, we currently have the expected mortality both for IHD stroke are these. So let's consider now a scenario where Chile, rather than improving treatment, so let's say that there's limitations in availability of treatment. So rather than improving, we see a reduction from 82.2% to 70%, let's say. Let's see what happens. Hypertension population control drops to 28.7% from 33, which was the baseline value. And you can see that the figures turned red. This means that rather than, in this scenario, rather than averting deaths, we are seeing an increase in deaths because there's been a reduction in treatment among those who are aware of the condition or have been diagnosed with the condition. Excellent. Later on, you're going to show a positive scenario, but this is just as a reminder. You can stop sharing, by the way. That's what I'm saying. Go to the link that has just been pasted on the chat so you can download the tool and use it. But let's go back to Marcela. What do you think? This is a tool that we can use for decision makers and politicians. Unless we do things right, this is what can happen. It's a very powerful tool because it can be used in the different settings where health services are provided. So once again, congratulations to Chile, Marcela, and your team. Luis Michela, who's a tireless collaborator. Paula, congratulations on the article. Hopefully people will read them. And Damian can tell me whether this article has been approved, but it's an impact on mortality, which is in the pipeline. It's from Chile as well. But take this as an example, because you need to assess hearts, and this is a way to do it. And since we have a community of cardiologists and academia here, use hearts as a platform. Build it based on evidence. We're not giving people misleading information. We say, go and see what we're doing, compare protocols, compare our actions, compare what it means to take pressure with validated devices versus non-validated devices. How many errors do we see? And how does this impact mortality? Anyways, I believe this has been a very good year for Chile. You're coming out of the pandemic like everybody else, but you are resolved to moving forward. And you will move to 100% of your medical centers with hearts, which is huge. Marcela, one country came in front of you, and I know. And this country is going to speak now. This is Trinidad and Tobago. In Trinidad and Tobago, 100% of their healthcare facilities are using the protocol. So congratulations to Chile. And with that, I would like to welcome Dr. Rohim Doon, advisor at the Department of Health Promotion and Public Health Communication at the Ministry of Health in Trinidad, and who will introduce an article showing findings, and then we'll go back. So technical support, please show this summary from Trinidad and Tobago.
Improving cardiovascular health with the patient-centered integrated primary care heart module in Trinidad and Tobago. This article describes the introduction of the Pan American Health Organization's Heart in the Americas program in Trinidad and Tobago, and the successful experiences and challenges encountered in introducing and scaling up as a strategy for strengthening the health system's response to cardiovascular diseases. Evidence about implementation of the HEART program in the World Health Organization's region of the Americas was carried out to identify the progress made, barriers, success factors, and lessons learned. In 2019, the Ministry of Health commenced the implementation of the HEART program in 4.9% of the 102 primary healthcare centers, and by the end of 2021, it had been scaled up to 46 centers, or 45%. The HEART program ensures that patients' cardiovascular health is managed in a comprehensive using a monitoring and evaluation system and a team-based approach to care delivery. The barriers encountered during implementation include the fragmentation of the existing healthcare system, the paternalistic role assumed by healthcare professionals, the resistance of some healthcare workers to change, and a lack of team-based approach to providing care. Successful program implementation was enabled through ensuring high-level political commitment, establishing the National Heart Oversight Committee, ensuring stakeholder involvement throughout all phases, and implementing a standardized approach to care. When implemented in the context of existing primary healthcare settings, the HEART program provides an exceptionally well-integrated and comprehensive model of care that embodies the principle of universal health care while ensuring the health of both populations and individuals.
Muchísimas gracias por este
Thank
resumen
you so much for this summary of the article led by Professor Rahel Bloom from Trinidad and Tobago for the Pan American Journal on Public Health. So now I'd like to invite Professor to turn on your camera. I don't see you. I don't see where he is. If somebody can tell me where the professor is. Jenny, I don't know if you can help me. But going back to the issue of Trinidad and Tobago was one of the countries that started implementing HEART in 2018. You've heard that before, and it's a huge example to follow in the Caribbean. And actually, countries in the Caribbean that are looking at incorporating HEART are reaching out to Trinidad for help, like Belize and Suriname, which has recently incorporated HEART. And they are doing an outstanding job. They've made a lot of progress in implementing HEART in all of their healthcare facilities. And HEART has been a model for Caribbean countries to also change the way in which they provide care. But I don't know what's happening with Rahel Dun, but I was thinking that Ramon, if you are still around, we were going to show another case study. So going back to the tool with Trinidad and Tobago as an example, we developed a negative scenario for Chile, not because that is the case, but rather to see the impact of a disruption of the program has. But now we're going to have a country that has 100% of their facilities using HEART. So what advantage could it be for Trinidad and Tobago, because it's one of the countries that has the highest rate of cardiovascular disease-related deaths in the Americas and the highest cardiovascular disease burden. So that's why they embrace HEART as much as they did. So how about we look at a case with Trinidad and Tobago? Let's go back to the HEART tool. Ramon, so the first thing you do is go into location, and that's where we select the country, right? Yes, I wanted to let you know that this tool is very versatile. It can be tailored to any kind of population. You can put any kind of name here, any kind of total population, that is to say, you can use this for a small geographic areas or a specific sector of the population or a population group that receives a certain service from a local healthcare facility, etc. However, if you want to do a countrywide analysis, then the tool already has this reference menu with pre-populated information for each one of the countries in the region of the Americas. So I'm going to select now Trinidad and Tobago, which has 1.5 million population, and population hypertension control is roughly 21%, 20.9%, which is quite low. There's a pretty significant gap to improve. Awareness, 60%. Treatment among aware, 77.8%. And hypertension control among treated, 44.8%. So we're going to see how we handle the case of Trinidad and Tobago. Here we have the baseline. Rather, we have the name. Parameters will be replaced with the data. I mean, the parameters will be pre-populated from that menu. We have the name of the country, population, and for each one of the population hypertension control values, baseline, treatment, and control are already there. These data come from this menu, and all we're going to do is kind of play around by developing a scenario where we're going to define what our targets are for this treatment cascade. So, Ramon, apologies. I believe that we could underline one concept, that the 80-80-80 concept, which we kind of mentioned, but we didn't specify anything. WHO and Resolve to Save Lives, which is one of the main donors, launched a worldwide campaign similar to what we did with HIV, TB, etc. And they used to get 80% diagnosis, 80% treatment, and 80% control among aware. So, Ramon, 80%, let's put 80% diagnosed, that is to say, from 60 to 80% as 20% improvement. That's for baseline. Treatment among the who are aware is pretty much the same because it's at 77.8%. So Trinidad does not have an issue with access to medication, but rather with diagnosing people. And another issue was with control among those treated. So let's take this from 44.8% to 80%. Let's see how that plots out. We can see how the values for diagnosis, treatment, and control among treated were taken to the 80-80-80 rule that you just mentioned, which gives us our target level for population hypertension control of 51.2%. So we will go from this current level of almost 21% to 51.2%. And this means that over the period of time, that in this case it's 5 years, it could be less, it could be more, depending on the capabilities the national program has to achieve these targets. But in this scenario, anyways, we could save 1,222 deaths from IHD and 462 from a stroke in that period of time. In a country with a population of 1.5 million, let's remember that. I believe, Ramon, that this is perfect to conclude for now. In our upcoming webinars, we're going to give you another case study, but again, go to the link that's being pasted, go to the tool, read the articles, and also Professor Rohil Dun's article to see how Trinidad has made progress. And Trinidad's article is entirely policy-based. They've expanded HEART towards all of Trinidad and Tobago, and it's been extremely useful. So without further ado, I would now like to go to Mark Tapia. Hopefully, Mark Jaffe, I hope he hasn't left. So Professor Mark Jaffe, are you still around? Oh, there he is. He is resistant to the HEART webinar. Mark, what do you think about what you've seen so far? Go ahead.
Well, I think the first thing is that it's really fantastic to model what we've all felt to have been the case. So I think it's one thing to sort of have a general idea that treating high blood pressure prevents heart attacks and strokes, but to have evidence that quantitates it and then to be able to model it and move it forward, really, I think will help. It helps in a number of ways. It obviously will help individuals who are treated, but not more importantly, but also importantly, I think it's nice when you're starting to think of this in a larger context, when you're laying a framework to speak to policyholders, to leaders, to pharmacies, to procurement, to people who may have questions about whether they should reallocate resources for task sharing. So I really believe, I certainly believe in the numbers and know that as hypertension control rate improve, we'll see positive outcomes. But I really like the power of the information. It's not perfect, nothing is perfect, but it's a lot better than we had to be able to model what the expected outcomes are. So I see this as yet another really important tool in the toolbox. And PAHO and Hearts of the Americas has so many tools to use. This is just another great example. So I'm really excited about it. So thanks, Pedro, for asking.
Muchísimas gracias.
Thank you so much, especially coming from Mr. Mark Jaffe, who has a lot of information. You built the Kaiser Permanente system. You have notoriously contributed to this concept of hypertension being disseminated all over the world, disseminated as a topic. China, India, Bangladesh, Vietnam, Kenya, Ethiopia, etc. There's a lot of places that this is being implemented in, and we're seeing the difference. So it's a pleasure for us to be aware of that. And now I'm going to conclude with a brief pause. You're going to hear from Mark Jaffe again because he's a guest speaker. Mark Jaffe, ladies and gentlemen, who's talking about standardized protocol to manage hypertension control. Go ahead, support team.
Hi, I'm Dr. Mark Jaffe. I've spent 25 years treating patients for hypertension at Kaiser Permanente, where we improved blood pressure control rates from 44% to 90% using a simple, practical treatment protocol. I want to share with you why it's so important to move from hypertension guidelines to simple hypertension protocols. The best protocols have specific drugs and specific doses, and they have a linear, one-step-at-a-time approach. Here's a great example from Punjab, India. It's easy to understand, and it has just 3 drugs. A simple protocol is best for blood pressure control for 3 reasons. First, it's just 1 page, so it's easy to train healthcare workers. Second, there are fewer medical errors when doctors and patients have simple instructions to follow. And third, a good protocol makes it a lot easier for pharmacies to forecast which drugs will be needed. It's also less expensive to buy larger quantities of fewer drugs. Each country or health system should pick a protocol that works for them. This is based on the drugs available in their country and the drugs that the doctors are comfortable using. Of course, when patients don't tolerate specific drugs in the protocol or who have side effects, they're managed differently and often by specialists. But most patients will be treated using a standard protocol. Now, the drugs selected should be low cost, and of course, they should always be safe and effective. The bottom line is that simple, practical treatment protocols have saved millions of lives already, and they can save millions more.
Bueno, muchísimas gracias. Como le decía,
well, thank you so much. As I was saying, we're going to hear from Mark Jaffe again. It's a way to acknowledge our partners from Save Lives and also our colleagues from CDC. Today, we're also joined by them to hear about what's happening around hearts in the Americas. Finally, I'd like to give the floor to hear the message on World Heart Day to Professor Daniel Piñero, President-elect of the World Health Federation, and also a tenured professor at the University of Buenos Aires. Daniel, go ahead, please. Hi, Pedro, how are you? Can you hear me? Yes, go ahead.
Bueno, primero felicitarte.
Okay, first of all, I would like to congratulate you on this outstanding webinar. I've liked it a lot. I've been paying close attention to all of the presentations. And honestly, this is a wonderful communication tool. And we have heard very rich experiences. I've been a partner of Hearts for a long time, and I've seen an extraordinary growth in this initiative. From my position as president-elect at the World Health Federation, I would like to tell you that WHF is an organization that brings together over 220 partnerships, foundations, groups of patients, etc., that are interested in cardiovascular health with presence in over 100 countries around the world. In this regard, the World Heart Day, which is September 29th, is a very important day for all of us. Even though we need to work on this every day, every minute of every hour, it's kind of like Mother's Day. This is the day where we all together bring gifts to our mom. Well, September 29th is the day where all of us will reflect on cardiovascular health around the world. So you know that cardiovascular disease causes more than 18 million deaths a year around the globe, and that hypertension is the #1 risk factor for cardiovascular disease around the world. So honestly, we'd like to congratulate PAHO on this huge effort, which has been so successful, where the main characters are each and everyone who in their communities will implement this protocol. Now, going back to the World Heart Day, I would like to tell you that our phrase is use your heart for a more equal world, use your heart for nature. We are very concerned with environmental pollution and climate change, and use your heart to exploit all of our potential and our capability of living a full life. Hypertension control is one of the key aspects to achieve that. So I would like to invite you to all come together on that day. It's not the World Heart Federation Day. This is everyone's day to, like I said, reflect, to think about, and to develop efforts so we can all build a better world for us, and especially for our children and our grandchildren, our all future generations. So Pedro, a big hug for you from Buenos Aires. I know we'll see each other soon in Brazil and later in Argentina. So we'll have the pleasure of sharing a lot during October. But mark your calendars for September 29th, where we can all celebrate World Heart Day. Excellent. Thank you so much, Daniel, for your kind words. And Daniel, I would like to take this opportunity to say, has been acknowledged with the University of Buenos Aires Award as a VIP on medical science in recognition for his career and leadership. And for the region of the Americas, it is a privilege without being chauvinistic, but it's very important to have a Latin American representative as the new president for the World Health Federation. Hopefully, we'll be able to do a lot together in during your term. So congratulations, Daniel. I had something in the tip of my month that it almost slipped my mind. Panama, which is one of the countries that is implementing HARTS, has been acknowledged by the Interagency United Nations group and WHO with one of their awards of the year on the implementation of HARTS in Panama. So to the entire team from Panama who have made a significant difference, to the PAHO team in Panama and to all of your leaders there, Ministry of Health, etc., a big congratulations on this award. This year, we also saw Ecuador being awarded as a country who were missing on this special issue on the Pan American Journal on Public Health with an award from the World Hypertension League. And there was also an award by Professor Don de Petit, one of our consultants by the World Hypertension League. He will be present at a different webinar. So we're concluding this webinar with a full room. Nobody has left, which is amazing. I don't know how you've been able to stay this long, but congratulations to everyone and thank you so much to everyone. We have been Stop Hypertension from the Complutense University in Madrid. We've heard that this university is using HARTS materials in training their medical students. So let us imagine the dimension of what you're doing. So thank you very much. Thank you to our technical support. Special recognition to Damian Vasquez, the editor of the journal, for this excellent special issue on HARTS. Thank you to my colleague, Andrés Rosende, who has enabled the communication with our authors, and Jenny Rodriguez is behind the scenes doing everything that needs to happen to have this webinar. So if you're there, please turn your mic on. If you have your cameras off and you've been working behind the scenes, please turn your cameras off. Let's have all of our participants now, panelists, everyone who's still with us, please turn your cameras on so we can take a group picture to have a record of participants, presenters, and thank you to our interpreters who have been conveying all of this message nonstop for the past 2+ hours. Thank you to our admin team, assistants, etc., everyone working behind the scenes. We are extremely happy. We have 512 people still with us.
Really impressive. We have reached 527. That was the maximum we reached. We tried to add the YouTube channel so that you have it recorded. We can use it, and hopefully you'll use the supplement of the issue of the Pan American the Pan American Public Health Journal. We've got to teach the medical students what we have to teach them. The material is all there. And I think that we have to take the next step, because if you're a professor from one of the most prestigious universities of Latin America in the world, which is the Buenos Aires University, you have to figure out how we're going to bring the people in to use this material. Congratulations to all of you. Thank you all very much for participating. Thank you to the PAHO communications team for making this possible. And once again, thank you to everyone. Are you taking the picture, Jenny? Who's taking the picture so that we have everybody on the picture? We took some pictures already. Okay. Fix your hair and your nails and your tie so that we can have a pretty picture. What a fabulous, let's give a round of applause for everybody, and we'll see you in the next HARTS webinar of the Americas with the Pan American Public Health Journal that's reaching its 100th anniversary next October. Thank you all. We'll see you soon. Let's hear the music now to end our event. Goodbye. Greetings. Now you can talk all you want.